Cool. Got it. So that's how you change your name if you need to. Now, where's my changing gone? Suddenly decided that it doesn't know how. Oh, it's doing drop down. That's why. There we go. Sorry, back. So that's our agenda, but that was the little welcome and housekeeping that I've just done. We're going to, Owen's going to do his talk about managing suicidal ideation in high-risk patients. I'm going to little add on at the end about local referrals and health pathways. Amanda's going to talk about the IAR tool, and then we'll conclude at 8 o'clock. So, and just very quickly introducing us, I've already introduced myself. I'm a general practitioner and I'm the clinical advisor here. And then Dr. Owen Harris, who is going to be giving the bulk of our talk, is also a practicing GP in a North Medical Clinic in Brunswick, and has a wide range of experience in all of the beauty of general practice, but particularly around mental health stuff that we're talking about today. So on that note, I'm going to unshare my screen and hand over to Owen.
Yeah, thanks, Jenny. I'll just get my screen up. Hoping everyone can see that one. Yep, so as Jenny said, yeah, I work in private practice in Brunswick East at the moment, but yeah, I have worked across a number of other settings. And yeah, today we're talking about how to manage high risk and yeah, focusing really on pathways and what to do with people. Sorry. So yeah, the question I think a lot of us face, and certainly myself, having worked in different settings, is you've done the assessment, you've determined that somebody is high risk, but what do you do with them now? And that's really the kind of oh shit moment that I've had several times. And yeah, acknowledging that people here work in a range of different sectors and have trained in many different places. And I think really that the where to send people, what do I do, how do I manage this person, is really the bit that gives most of us the anxiety. So just a few numbers there. At any one time, sort of 20% of the population is living with mental health issues. This number in the middle, I'm not actually sure where that 12% comes from. It might be from the MBS data, which is clearly not necessarily the most accurate way of assessing things. But according to the numbers I found, sort of 12% of GP consultations relate to mental health issues. Obviously, that really varies depending on your practice. For me, it's very much higher than that on any given day, and I'm sure it does vary depending on your own practice. Importantly, though, on the right-hand side, about 45% of people who have suicided did visit their GP within 1 month. That also means about 55% haven't, but yeah, it does mean that there's this huge opportunity to sort of reach about half the people who are very much at high risk there. So just as I said, we're not going to talk too much about making the assessment, but just to cover some of the high risk factors. And I think these are really important to consider when you are thinking about where to send somebody or what to do with them. So somebody with a mental health disorder with clear and immediate plan of suicide, people who are more impulsive, people with concurrent substance use or risky substance use, I should say, people without support, and people without other protective factors like work or family or other things. So yeah, I think these things are really important to consider and individualize your treatment plan when you are seeing somebody who you consider to be high risk, because it's really going to change what you do or who you call. So this very busy and confusing slide, I just wanted to throw in to reassure you all that, yeah, it's the health landscape in Australia is very complex. It changes depending on where you work. There's lots of different bits. The bits all don't necessarily talk to each other. And where we are in that slide, general practice on that second rung is really just kind of one little key in the cog, but it's actually a very important and big part, really, in terms of what people need and who people see. For many people with mental health issues, the GP is the first person that they see. And for a great number, particularly through COVID and even until now, GPs are the only mental health clinician that a person might see with their mental health issues. So they're really not involved in any other part of this system here, even though they do all exist. And yeah, as I said, that landscape is going to change, not just state to state, but area to area. So it's referrals generally, but particularly in mental health, I've found to be a pretty anxiety-inducing part of the job. And it's just to remind us all that it is complex and that you can't possibly know all the parts of the system. And then to confuse us all even more, I've got this incredibly busy slide. This is taken from a website, Mr. Perfect, which is a mental health community organization. It's highlighting some, but not all, of the different mental health organizations in Australia. And you can see there's a huge number of different organizations in different parts of the system. It is a men's health organization, so there is a focus in the middle of the slide on men's health, but that's just because I've stolen the slide from their website. As you can see on the right-hand side under crisis, there's only a couple of services listed there. So yeah, it's a little bit more condensed in the pointy end, but there's a huge number of other organizations that people may or may not know about. We can't possibly know about all of these services, but it's helpful to have some kind of idea about some of the bigger ones, and also just being aware that people will come to you with their own Googling and information that they may have sourced from a range of different places online. So in terms of the crisis services, this is how I've kind of just grouped the different more kind of important used and often used services for myself. Obviously, there's the public hospital and particularly the emergency departments, not where we necessarily want to send people, and I'll come back a bit about that later, but obviously not the best place for most people with mental health issues, but a very important and necessary place. There's the CAT services, or the triage services that are run by the different area mental health services. There's private mental health hospitals, or private psychiatric hospitals rather. There's the Care in Mind services, which access private psychology. Despite what we all may experience in terms of referrals, there are actually private psychiatrists who may be able to take new patients or are managing your patients already. There are the head health services. Also, there's always important to remember the drug and alcohol services, both outpatient and inpatient. And then there are all the other supports in the community from the slide I've just shown you before. So yeah, any or all of these, a number of these services may be involved in a single patient's journey through the mental health system. And when a person comes to you in crisis, they may already have some of these supports that you can then talk to and access, or they might come to you completely fresh without any involvement with any other services. So yeah, as I said, we're not going to talk about assessing risk, but in terms of management, I think a really important step is safety planning. And that's something that you can be discussing and encouraging your patient to do. It could be something you do with your patient in the room, or it could be something you ask the patient to do and come back to you with. And for me, one of the best tools that I use is the Beyond Now app, which I hope people have some familiarity with. If you haven't seen it yourself, it's worth downloading and actually just running through the steps yourself. It's a nice, concise app for people to do their safety planning and to store important information. And when we're well, it's very easy to look things up online and to kind of think clearly about things. But if a person's unwell, then it's everything can become quite overwhelming. So if you can encourage them to do some safety planning, and if they can download the Beyond Now app and have somewhere to store all of that important information, it's much easier to get back to when you actually need it. It's also been shown that actually doing safety planning itself can help reduce suicidal ideation and reduce distress for people. So there's 7 parts to creating a safety plan. These are the 7 steps in the Beyond Now app, and each step is clearly laid out. So it's about recognizing warning signs for a person when they're becoming more unwell. Then creating a safe space. That means removing things that can create distress or could be causing more risk, like substances or sharp objects, things like that. It's listing reasons for living for a person. Then it's moving on to things that they can do themselves that reduce distress. It could be exercise, it could be spending time with family or their pets or art or other programs. And then number 5 is connection. So it's about being with people that make them feel less distressed, and that might be face-to-face or online. So community forums, mental health forums are certainly an excellent and important space for people. And then number 6 is people that you can actually talk to about your suicidal thoughts, people that are able to hear those and increase safety. And then the last step is professional help. So important phone numbers and other people that you can talk to in terms of getting professional help. So just on the screen, there's a few numbers there that are 24-hour mental health crisis services. And yeah, those numbers are widely available, but can be hard to find if you're feeling distressed. And yeah, it's really important that a person can easily access those services. So putting those in the Beyond Now app and having a safe place to store them is really useful. Safety planning is going to change depending on how well supported a person is. But something I really wanted to highlight is the power of regular GP review or review with other existing services. It can be really overwhelming for a person who presents with kind of distress and high risk to then be shuffled off to a bunch of other services or to be sent to ED. And often the case is if a person does do that, or if a person's highlighted as high risk, they'll then have kind of everything thrown at them, and they'll be on the receiving end of phone calls and other services often from private numbers, and that can be really overwhelming. It also can take time for many of the other services to kick in. And so in that time, a person might feel kind of adrift, and it's really, really useful and reassuring if they can see you regularly, somebody that they know and trust, somebody that they've already disclosed their thoughts to. And for some people, they certainly do need all the other services, and that's really important. But for other people, just actually being able to sit with them and be with them and support them through that time is often enough. Is often enough for them to ride out the sort of highest risk and most distressing part of their mental health issues, and then for things to kind of calm down, and also gives you time to engage the other services that they might need. So before I move on to some case studies, I just wondering if anyone has any questions they want to either mention in the chat or unmute themselves and yell out. Is there anything there, Jeannie, that you wanted to? No? Okay, great. So these are just some case studies from people that I have seen. It's just the story as it has happened. It's certainly not the right or the wrong way to do things. I'd be very open to ideas, and obviously this is going to change depending on where you work as well. I've kept them pretty brief intentionally, just so if there is some discussion about the case, I'd be more than happy for people to unmute or to put their question in the chat. So JD is a 24-year-old cis woman who has no known history of mental health issues, came into the clinic acutely psychotic. She lives in a share house. Her family's in regional New South Wales. And she'd actually just came into the clinic, no appointment, was seen in the waiting room, kind of making a pile of sticks in the corner, and had kind of a range of kind of things around her that she'd brought in from the street. So the receptionist approached her to ask her what she needed, and she said she wanted to see me, but she was clearly acutely psychotic. So I saw her. She was not expressing any suicidal ideation, but she had very poor insight. She'd created a little love letter to give me, and she really wasn't making any sense at all. So I rang the triage line to let them know. They advised me that she needed an admission, which I agreed with. So then they instructed me to call the ambulance, which we did. She presented probably sort of, I don't know, late afternoon on a weekday. We called the ambulance and then we waited. And this is probably an experience many of you had, that we just waited and waited and waited. By about sort of 7 p.m., everyone else had gone home except myself and the practice manager. And we were still waiting. And then we kept calling the ambulance, but were given no indication of when they might arrive. And then we're not exactly sure what happened, but I think I went to the toilet and the practice manager was distracted, and the person did a runner, managed to run out the side door and went home. So we tried to call her. We then called the police to do a welfare check because we had her address. Obviously, if she was an existing patient. And they said they would follow up, but there really wasn't much else we could do. I did call her mum and let her mother know, and her mother started to drive down from New South Wales. So it turned out she'd gone home. Her housemates kind of supported her overnight. They'd also spoken to her mum, who then arrived by the morning. They represented in the morning, her mum and the patient, and after discussing things with her mum took her down to emergency herself, and then she was admitted for 2 weeks, started on some antipsychotic medication. It was thought that it was a drug-induced psychosis kind of triggered by university stress and lack of sleep over a few days. And then after a few weeks, her psychosis settled, and several months later, she was off all antipsychotics and was back at uni. So in terms of this case, yeah, I think calling the ambulance was in the circumstances understandable, but given the stress that Ambulance Victoria under, it was not really the right thing to do. Yeah, I was concerned given she was in a share house and didn't have many other supports, but yeah, getting to the hospital was really the problem, and unfortunately, that's just kind of the system that we're in. In hindsight, the receptionist herself had offered to drive the patient to the emergency department, and I'm not sure if that's actually legal, but it would have probably been a much better outcome. But other than that, yeah, I'm not sure what other people might have done in that situation. If anyone wants to yell out, Jeannie's got a hand up.
So, Owen, I'm a foreigner, and am I unmuted? Yes. I'm a foreigner, and I'm just wondering, how did I've arrived at your practice. I started working there yesterday, and this woman's arrived, and I'm looking after her. How do I know this triage helpline that you talk about that you rang? How do I find out about that, and how do I know who to phone for this admission?
Yeah, good question. So, yeah, depending on where you work, the area mental health services are located around the country, and particularly around Victoria. Each have their own triage number, and it can certainly be very confusing. They all run in slightly different ways, and some of them can be much quicker about answering the phone. It also varies depending on how busy they are, obviously. So I've certainly had some experiences where I ring and they answer immediately and give great advice. Other times you sit on hold for a very long time, and they might answer, or they might offer a callback service. And obviously, you're running a general practice, you've got other patients lining up. So it can get very difficult. But in terms of actually finding the numbers, I've got a slide at the end which lists each of the different area health services and their triage numbers. Often I just Google myself and end up sort of finding the right number. But it certainly can be quite confusing. If you'd called emergency and spoke to the admitting officer, I'd hope that they direct you to the area mental health service. But it certainly can be very confusing. In our region, it is based on the person's postcode. So I've had patients present to me who live in other area services, and I've called the wrong service and started the whole process, and then they've taken some details and I've had to call somebody else. So it's definitely a very messy system. It's also not a crisis service, even though that's what it's sort of implied that it is. It's an assessment and triage service. So if you were in the community and you called that number and somebody was acutely in distress, they would potentially call the police and the ambulance to arrive. And that should really be the same approach in your practice. If the person's really acutely unwell and at risk, then calling the ambulance or the police first would be my suggestion, not waiting for triage.
Owen, Deb Edwards has something she wants to say as well, but hasn't got the hand up feature.
Sure.
Good morning.
Oh yeah, sorry, Deb. I thought you meant
no, that's all right. I, for some reason, couldn't find my little hand. Just so that people are aware, understand the public mental health triage service is quite chaotic, given it runs on catchment areas. If you go onto the Vic website, I always just tell people to put Victorian Mental Health Service, and what comes up is the letters of every single town in the state of Victoria. And you can go to adult triage, child adolescents aged, and it'll give you the direct numbers, the different services that you need to access, whether it be CATs, rostered function teams, EMH, PACES, or you just want community 2-year case management type scenarios. It's probably one of the best websites you can get to always know in your own practice who your 1-300 number is, and that will give you all the services that you require.
Yeah, great. Yeah, thank you. And there is a slide at the end with some resources that's included. And yeah, I should actually say also that these are for adults. If it's for people under 18, then the Origin would be the number to call.
Under 25 if they're first.
Sorry, 25. Yeah, thanks.
That's all right. Sorry.
Thank you. So I'll just move on. I've got a few case studies here. So number 2 is a 26-year-old cis man who presents with acute on chronic suicidal intention with a plan but no intent. He'd had a previous suicide attempt only a few months before. He lives in a share house. He has ADHD on medication. He already has a private psychologist. He's unable to see the psychiatrist who did the diagnosis, and is pretty unsupported. So this is a guy, I was new to me, and relatively new to the practice, had been struggling with mental health issues and suicidal ideation for basically a decade or more. He'd only had that one attempt, but that was fairly recent. Kat had followed him for, the crisis team had followed him for several months, but he'd lost his job and things had got worse. So this is a guy who had very good insight, clearly had some borderline traits, and he understood the mental health landscape very well, given his long involvement with them. He was certainly traveling worse than his baseline, but I was confident that he would present if things got more distressing for him. So I did call the triage line and it alerted them to the fact that he was more unwell again, but I wasn't about to send him to emergency. There was no clear benefit from admission. So this is a person who I arranged to see regularly and continued to see regularly. It was always also somebody that I alerted to reception and to the patient that he was able to call me and book an urgent appointment if he needed. So I saw him regularly for a while, and then it became clear that he was starting to get better, and we were able to lengthen out the frequency of our visits. And yeah, several months later, he's still not back at work, but he's traveling much better. So move on to case 3. 31-year-old cis woman who presented with a manic episode. I'd been seeing her for some time, and I knew that she used some recreational drugs, but she was always a bit cagey about the amounts. She was an artist and also worked as a sex worker. She had a history of eating disorder and not very well managed. She had very poor insight and a lot of medical trauma. So this person came in with a friend, and the friend was also a patient who I had some knowledge of. She was, really acutely psychotic and very hypomanic. She was, making no sense at all, really. But it was very clear that she didn't want admission, and that if I tried to do a treatment order, that she would basically do a runner on the spot, and her friend was going to help facilitate that. She was very resistant to any medication, particularly anything that had a risk of weight gain, given a history of eating disorder. And yeah, it was unclear what sort of substances she was using. So she wasn't suicidal though, so she wasn't expressing any suicidal ideation. It was really just that she was so chaotic and unwell. So this person, I was a bit unsure what to do with, given I wasn't clear what was going on at home, what the relationship with the friend was. But again, we did negotiate a safety plan, and she did agree to a very short-term use of some antipsychotic medication. And again, the best thing for her was a regular review. So I saw her very regularly for the next few weeks, and she did calm down. Her maniac did calm down, and she was then able to engage in some private psychology. And she agreed to reduce her drug use in the short term. And yeah, I was able to see her regularly enough that things did start to settle for her. Any questions about that? No. So case 5 is a 23-year-old trans woman who presented with suicidal ideation. I'd been seeing her for a little bit of time for gender affirming care. Didn't know much about her mental health history outside of that, though. She had a history of depression and anxiety and had previously been on medication. She was currently seeing a private psychologist, very limited supports, and financial stress. And she presented with a clear plan. And I asked her if she could try and guarantee her safety until the next time I saw her, and she was very reluctant to do so. Basically unable to guarantee her safety. Living in a share house that had very few supports locally. She was involved in a few online trans peer support groups, and felt able to disclose things to people in those groups, but was really reluctant to consider any hospital or inpatient care because of previous traumas related to and issues related to being misgendered in the past, and was really scared about any engagement in the services other than the people she was already seeing. So this person, I was pretty worried about. I didn't want to lose trust with her. I didn't think she met the criteria for a treatment order, given she had good insight and was presenting to me. But I was certainly worried about sending her home. And this was one of the people that I did sort of lie awake at night thinking about. But I was able to speak to her psychologist, and between us, we were able to see this person much more regularly in the short term. And we did restart some medication, which I'm actually not sure whether it helped very much. But between the psychologist and myself and seeing her regularly, we were able to kind of monitor things through the worst part of her distress. So the next case is a 20-year-old cis woman who presented with suicidal ideation and self-harm. She had a past history of premenopausal dysphoric disorder and also depression. She had quite poor insight and was very impulsive. Some of the self-harm she was engaged in was really quite dramatic and quite extreme. She also minimized her symptoms a lot and felt like she was wasting my time. That was an expression she often used. And she had a baseline which was not too bad and certainly very functional. She was at uni and working in about 3 different jobs. But with the PMDD, she became really quite distressed and very impulsive, and the self-harm ramped up. And she also told me that she felt like each time it happened, she needed to do something more and more extreme. So this is another person I was quite worried about and spent a lot of time kind of thinking about when she wasn't there. Given her poor insight and a tendency to minimize things, I felt like she was higher risk, very high risk, and particularly higher risk than she appreciated. Having said that, she did have some insight into when she was feeling unwell. She didn't sort of appreciate why, but she was able to identify that she wasn't doing well, and she was able to come in and talk to me. And she did recognize that she did want things to change. So I referred her to Origin, and they triaged her pretty quickly, but it still took some time for them to actually engage her. And in that time, it was really important for me to keep an eye on things, because I didn't think she warranted assessment treatment order, but she was quite high risk. So we negotiated a plan to try and reduce the self-harm, which she was mostly able to keep to, but not entirely. But I was able to see her regularly, and particularly in the sort of highest, just the most distressing part of her cycle. Sorry, Jeannie?
It was just a comment really, Owen. I think we had an email chat while we were getting this presentation together, and I think this case so perfectly illustrates that role of general practice, of sitting with the patients, not always feeling like you're having to do something active. I mean, you've done lots of active things with her, but the key thing you did with her is sit with her. You didn't kind of do a runner because she was difficult. You saw that, you know, the best thing you could do for her was see her regularly, engage her, gain her trust, and just quietly over time, therefore, be able to siphon her off into the services that were going to help her.
Yeah, I think that's true. And, you know, given her age, and yes, she did present to me. I initially saw her for some physical health issues, and it was clear that she felt comfortable talking to me. And the last thing I wanted to do was break her trust by, breaking confidentiality or other things. She, had not been involved in the mental health system before and didn't sort of understand how it all worked. So yeah, it was really just important to be with her and support her through that process.
That's right. And I think that often we often feel pressure to do something, and we forget that being is doing something, and being with her is doing something.
Yeah, certainly. And with this person in particular, just validating her symptoms and making sure she understood that, yes, she had a right and deserved treatment like anyone else.
And just a comment on the chat, letting her know you were there and listening, and sometimes offering strategies to distract from negative thinking and remind her that she is okay.
Mm-hmm. How are we going for time?
Yeah, just going to tell you, I'm 2 minutes.
All right.
Thank you.
So this one, I might skip through to the final slide with some resources. But yes, certainly, yeah, I agree with Jeannie. We do often feel compelled to do something. I think that's just the nature of medicine and the way we're trained. And we often feel we need to solve things, but I think really it's much more important to think about soothing them and being with people and supporting them. And yeah, if the person is at immediate risk, then it's about calling the ambulance and or the police. But otherwise, yeah, the range of services that are available, yeah, I think the most important bit in the system is yourself and just the ability to be with people. Because knowing about risk doesn't make it any more risky for people. And certainly in the drug and alcohol sector, the sort of understanding of risk is very different. Just because you hear about the risk doesn't mean that you need to jump up and down and do something about it. So these are just some numbers that I use in the for most people in our region. It's the Northwestern Mental Health Triage Service, which is at the top. I did forget the origin number, which is for people under 25. There's a great list of telephone and online services for the public and for anyone else, which is that second website. And then the third one is what was mentioned by Deb. That has the alphabetical list of all the different mental health triage services. The GP Psychiatry Support Line, I don't know if people know about this, is a relatively new service. That's a secondary consult service for GPs. So it's to ring and get advice from a psychiatrist. It's a 9 to 5 service, I think, but I'm not sure. There's also the DACUS, the Drug and Alcohol Clinical Support, if you need advice about drug and alcohol issues. And lastly, we've always got to consider ourselves and the effect all of this has on us, or the rest of life has on us. And if you feel like you're struggling yourself, then the Victorian Doctors Health Program is really an excellent service as well. And totally.
Just a question on the chat there, Owen. Someone's asking how good and accessible is the GP Psychiatry Support Line.
I actually don't know.
Yeah, I've never used it. Yeah, I've used DCAS, and they answered. I think they have an hour callback policy. So but I haven't used the GP Psych Support Line. Sorry.
Yeah, I haven't used it either. And just, you do have to register for it. It only takes a few minutes, but I'd encourage you to register now so that when you do actually need to use it, you don't have to go through the registration step.
Okay. Are you happy for him to shift on to my quick few slides? Okay, so I'll do my share screen. So hopefully, yeah, so Jeannie Knapp back. I've just got a couple of things to build on from what Owen's chatted. Thank you, Owen. That was a very useful talk and reminder of our role as GPs. I'm hoping this is going to work. Why is my screen not changing? Oh, here we go. So I'm just really just building on a couple of things that Owen talked about, and firstly about that complexity of the health system that we're working in, and in terms of public key services in the public sector for people in our area. This slide from the PHN just kind of splits it into level of intensity. So on the right there, we've got the level of intensity. Sorry, on the yes, we've got the kind of low intensity, moderate to high intensity, high intensity. So we've talked about that public referral. So Owen talked about that patient who had to go to the emergency department, had to ring the psych triage service, and these are going to be the hospitals that they might end up in. And somehow or another, St Vincent's, which is my nearest referral hospital, fell off the slide. For the high intensity for our youth, we've got Origin, Royal Children's for the younger people. So this is a sort of a nice kind of idea of where things fit in that kind of medium intensity. We've got that Head to Health service, which can all be accessed through the PHN as well. So I'll come back to that in a second. So we're very familiar with the Medicare referrals for those low intensity services. It's as you kind of step it up that it's harder to kind of know about. There's another really interesting service called Safe Haven, which my team here let me know about, and Safe Haven are a peer-run service at St Vincent's, and the patient that Owen was talking about, who was very kind of cautious about being involved with any kind of medical tertiary services. Safe Haven can be a nice way to get that kind of conversation starting and link them in. It's literally a meet and greet in a cafe with a peer support service, and that might be that person who Obviously, you're not acutely sending them to ED, but that middle ground where you're wanting to think about getting them into some secondary services, safe haven can be a nice middle ground way to do that. The PHN itself has an enormous number of health services that you can refer through to. And it's previously been called Care in Mind, Head to Health, Head to Help, a whole bunch of things. And now it's just been streamlined to the Mental Health Referral and Access Team. So it's a lovely one-stop shop of, you can just use one referral form for that, and it's mostly for the lower and medium intensity. So it's not appropriate for that high intensity person who's going to ED. However, they do have an intensive suicide support service as well. So it kind of fits into that moderate intensity. So they're all of the referrals are referred by clinicians, which includes experienced mental health nurses, psychologists, and social workers. And it's just a one single form to refer. Now, while they will accept referrals for anybody, there is they are prioritised to certain high needs groups. So particularly those on low incomes, those who are homeless, people from CALD communities, queer communities have a priority. But at the end of the day, you can send a referral to the referral and access team for anyone, and then they will be triaged into maybe a private psychologist with the gap payment covered by this program, maybe into the Head to Help hubs, all sorts of places that they can be triaged off to. So that's a really important service. It's and it's just a one referral form, and the details are on that slide of how you can download that form and have it integrated into your practice software. And can mental health nurses use this? Great question. And I might have to get back to you on this. I don't see why not, but I might have to confirm that because I don't know the answer to that one. And then the other thing I just wanted to talk about was health pathways. So Deb put up earlier the one-stop shop on the Vic DOH website. Health pathways is another way to access all this information. So health pathways are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter. So they're all localized, and it gives us, again, on a one page. So instead of thinking, oh, I need to go to ETG, or I need to go to the cardiovascular guidelines, or I need to go to that page that Deb just gave me about mental health referrals, they're all in this one place. And it gives it's evidence-based and local referral options. And so just for context, I've put here the page on suicide prevention. So here's our local health pathways. I go to the suicide prevention page. It gives me my red flags that Owen talked to us about. And then we've got the referral networks if high risk, and you can click on each of the bits that are, so it says emergency department. If you click on that, it'll then tell you all the local emergency departments. Or phone the adult psychiatric triage service. If I click on adult, it'll concertina down to all of my local adult psych triage numbers. So I can think, okay, I'm in Richmond, but my patient is actually, and this was a question came up on the chat before, I work in Richmond, but my patient's actually over in Melton, say, and it will give me what is the appropriate triage number for my patient who lives in Melton. All in one place. I don't have to be finding all sorts of different places. It's all here on Health Pathways, which anyone in our catchment can subscribe to and have this all for free on your desktop. And then I'm handing over to Amanda, unless I'll just check that there aren't any other questions on the chat before I do that. The question about the mental health nurses wasn't about the GP psych service. It was about the GP psych service. Can GPs use the GP psych service? And I don't know the answer to that either, Owen. I don't know if you do.
Yeah, I just checked the website. It's a new service, so I wasn't aware either. But yeah, it does say exclusive to GPs on the website. But I can follow that up with the PHN and see why that's the case and if they're going to have plans to open it up.
Before I hand over, I just want to make one more comment. We've talked a bit about referring publicly. Don't forget that private hospitals also take also take our suicidal patients. The difference is they're not going to take that acute person who needs to be seen today. You've generally got to be prepared for between a 2 and 7 day wait if you refer privately. A referral private you send to your local intake team. So my local private hospital was the Melbourne clinic just up the road from me, and I send it to their intake team. But you have to have someone that you're comfortable to sit with and hold for that 2 to 7 day break before they will pick them up, as opposed to our acute ones which need to go through the public service. So Amanda, I am now finished and handing over to you.
Great. Are you able just to pop my slide up, Jeannie? I think it was just directly after that page.
I could do that.
Morning, everyone. I'm Amanda, the Training Support Officer for the Initial Assessment and Referral Decision Support Tool, known as the IRDST. I think it's the next slide, Jeannie, if you don't mind. Sorry. I am providing training for GPs and mental health clinicians. This is a Department of Health initiative. So it is funded for GPs to attend the training. Sorry, Jeannie, slide before. So we are basically matching a patient after initial assessment to a defined level of care. So levels of care are 1 through to 4, whereas 1 being their low intensity self-management, 3 to 4 being high intensity, sorry, 5 levels of care being high intensity. There is a QR code there if I am available to deliver the training face-to-face online, face-to-face in your practice, or I can set up an online session for your practice. There are regular, I do probably 1 to 2 a week of open sessions, so you're welcome to jump on our website and register for a session. Again, it is funded for GPs to attend, and you do receive RACGP CPD hours, and mental health clinicians are also welcome to access the training. My details are not on there, but if you have any questions, then you can just contact the PHN and I'll be only too happy to assist you. Otherwise, if you scan the QR code there, you can pop in your expression of interest and I will get back to you via email and let you know the next available training or sort one out for your practice.
And if I can just make a comment, Amanda, those mental health referrals that I was talking about into the PHN, they're using the IARDST to stratify where patients are, what level of service they're sent to. So if we don't do the IAR assessment, someone else will, and it makes sense for us to do it because we know our patient, we've got them in front of us, and I'm finding that it takes me about 2 minutes to do it. I've done the training, it's about a 2-minute whip through the website and do the assessment that I can then include on my forms, and then when the referral's received at this end, they can much more quickly allocate them to the right place.
Thanks, Jeannie. Alrighty, are there any questions or comments at all about anything Jeannie's gone through or anything else left for Owen? No, I don't think so. I think you can carry on there, Jeannie. Did you want to close the meeting, Jeannie?
Certainly, sorry. I am sorry. I was just, yeah, so thank you, everyone. I've just scanned the questions. There doesn't seem to be any other questions on there. You're going to get your post-session email, which will include all these slides and your attendance certificate within a few weeks. Those important points go up within 30 days. And there's a couple of links there. There's a link to get the recording if you think one of your colleagues might like it and you want to forward it to them. If you want to go to further sessions, there's a link there. And of course, we'd love your feedback. So please scan the QR code and give us all the feedback.